Hello, everyone, and welcome to today's webinar, Risk Stratification of the Apparently Healthy Population with Architect Stat High Sensitive Troponin I. I'm Christy Jewell of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Abbott Diagnostics. To learn more, visit abbott.com. Now, before we begin, I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. To do so, simply type them in the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. If you have trouble seeing or hearing the presentation, click on the Support tab found at the top right of the presentation window, or report your problem by clicking on the Ask a Question box located on the far left of your screen. This presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab located at the top right of the presentation window and follow the process to obtain your credits. I now present today's speaker, Dr. Gillian Murtagh, Associate Medical Director, Abbott Diagnostics. For a complete biography on our speaker, please visit the Biography tab at the top of your screen. Dr. Murtagh, you may now begin your presentation.
Hello everyone, thank you for the introduction and welcome to today's webinar, Risk Stratification of the Apparently Healthy Population with Architect High Sensitive Troponin I. Disclaimers: Architect Stat High Sensitive Troponin I is not commercially available in some countries, including the USA. Risk stratification claim, as it applies to this webinar, for Architect Stat High Sensitive Troponin I is only available to be used in CE marked countries and in countries where regulatory registration has been completed. My disclosures: I am a cardiologist. I trained across several continents, including the US. I have a clinical background with ongoing research activities, and I have been a full-time employee of Abbott Diagnostics since 2015. So what is risk stratification of the apparently healthy population for future cardiac events with Architect Stat High Sensitive Troponin I? Risk stratification is a tool for identifying and predicting who is at risk, be that low, moderate, or high risk, or likely to be at risk, and prioritizing their care in order to prevent worse outcomes in conjunction with clinical and diagnostic findings. And those worse outcomes include things like heart attacks, heart failure, or indeed death. Why is risk stratification in this context important? We all know that mortality trends for cardiovascular disease are projected to continue to rise. And really, mortality due to cardiovascular diseases is extremely important because death from cardiovascular causes is the #1 cause of death worldwide in both men and women. And how do we approach risk stratification in people who don't have symptoms today? We have multiple risk stratification tools, like Framingham 2008, which includes age, sex, smoking history, all of the conventional risk factors. We have SCORE from the ESC, the European Society of Cardiology. We have the pooled cohort equations from the ACC and AHA. These are similar multivariable assessments. We do, of course, use circulating biomarkers, and we do use profiles such as the lipid profile, and in some institutions, high-sensitive CRP, which is a biomarker of chronic inflammation. And what we do with those tools is that we determine the level of risk for future cardiovascular events. People can be either low risk, and in that case we would usually give lifestyle advice. They can be moderate risk, where we would give the same lifestyle advice but also consider drug or medications if risk factors remain uncontrolled. And then you can be, of course, high risk. And in that case, we would again give lifestyle advice, and in this case, it would be very unusual not to give drug or medications. So that's what we do today. However, there are limitations to the current methods. In general, they do correlate to the risk of cardiovascular disease somewhere in the body. In other words, they are not necessarily specific to the heart. So one thing that's important to note is that it is coronary disease or heart disease that is responsible for most deaths. Yet the tools we are using, though they are extremely important, like blood pressure, lipid profile, and looking at things like smoking or whether or not the person has diabetes, they're very important, but they are not predicting risk specific to the heart. Secondly, they may also be inaccurate. Some tools can overestimate or underestimate a person's cardiac risk. Thirdly, they may be dependent on age inappropriately, to the point where age can inappropriately influence the risk status of an individual. So, in other words, if you have an older person, they would be automatically categorized as higher risk purely due to their age. And as we know, there are lots of older people whose risk would not correlate with their advanced age. They may be at lower risk, and that is not accounted for in many of the existing tools. The other issue is that there are, with some of the markers, cutoffs that do put the majority of people at moderate risk or greater. And with some tools, such as HS-CRP, an overly large proportion of the population may be categorized as moderate or greater risk, depending on the cutoff used. So there are limitations. The other issues include things such as the fact that soft endpoints rather than hard endpoints like death were used for some of the risk calculators. With other risk calculators such as ACC family history was not always included. With other calculators such as Q-risk, which was compiled from UK data, this was not considered random, and there was a lot of missing data in what was included. And of course, if you are going to use something like the lipid profile alone, it would not account for some of the risk factors that we consider conferring highest risk, like smoking or diabetes. So some of the risk tools, in other words, didn't always include hard endpoints. Some of them didn't always include certain factors like family history or treatment of diabetes or blood pressure, which could greatly modify the person's risk, and others simply do not account for some of the most influential risk factors. We also know from studies like this one by DeFilippis et al. Published in the Annals of Internal Medicine that the current risk scores, such as Framingham and the ACC calculator, provide an area under the curve of around about 0.67 to 0.71 when it comes to predicting future cardiovascular events. So there are definitely issues with the current methods. It has been considered that high-sense CRP could take the form of the primary circulating biomarker to predict these events in future, but recent reviews have suggested that it has a limited role in terms of its predictive value beyond traditional cardiovascular risk factors, and that it may only be useful for people who are deemed intermediate or moderate risk. So there are multiple publications here, this one from Folsom et al. And another from Miller et al., where it was shown in the ARIC, atherosclerosis risk in communities cohort, and in NHANES, very large US cohort, that the AUC was really improved by 0.003 on adding HS-CRP to usual cardiovascular risk factors. So really a very small improvement in ARIC. And in NHANES, high CRP was rare in the absence of risk factors. So really what you're seeing is that there was not much incremental value when you added high-sense CRP to the traditional risk factors. So, risk stratification of the apparently healthy population. We've pointed out that there is an increasing issue with cardiovascular disease. How can high-sensitive troponin I help? Cardiac troponin I is the preferred biomarker for the diagnosis of myocardial infarction because of its high myocardial tissue specificity, as well as its high clinical sensitivity. So we know that from current guidelines across the world troponin I and T are the recommended biomarkers to aid in the diagnosis of myocardial infarction. And of course, we know that troponin I tends to be more cardiac specific than troponin T in many cases. Troponin's presence has been shown in the bloodstream of apparently healthy individuals with no clinical signs or symptoms of cardiac disease. And the Abbott Architect high-sense troponin I is the first CE-marked cardiac-specific biomarker that aids in predicting future cardiac events. And we are going to explain some of the evidence behind that. It's important to note that when we compare the Abbott high-sensitive troponin I assay with the contemporary Architect troponin I assay, there has been a 7-fold improvement in precision, but without a significant change to the 99th percentile. And if you look at the figures here, you'll see that the LOD with the contemporary assay was about 10 nanograms per litre, and that is now about 1.9 nanograms per litre with the high-sense assay. And importantly, the 10% CV occurred at 32 and is now occurring at 4.7 nanograms per litre. However, the 99th percentile, as you can see, has not dramatically changed. It's gone from about 28 to 26.2, and that, of course, should not have changed substantially. The general population that's used for derivation of the 99th percentile has not changed. So we see, as we say, a 7-fold improvement in precision, but not a significant change to the 99th percentile. We do see that with the contemporary assay, we were detecting about less than 50% of normals with a detectable value. That has really gone up quite a lot, well over 50% with the high-sense assay. The percent detection rate of so-called normal subjects is now well above 75% for the ASPE publications that we're about to go through, and actually hits well above 95% in most cases. The other issue, as we pointed out there, is that it is a highly cardiac-specific assay, in that troponin I is very specific to the heart. So what we're getting at is that the assay has really provided a big improvement in precision, that you are now able to detect troponin I in people who appear to be normal, who do not have signs or symptoms, and that it is very cardiac specific. When we talk about troponin I and the use of this assay as a possible predictor of future cardiac events in people with no signs or symptoms, you would think that, of course, we would like to see that it does correlate with the presence of subclinical coronary disease as determined by imaging techniques such as, say, CT or MRI. You would want to see that the higher the troponin value, the more, say, coronary artery calcification was present. And in this study by Olsen et al., they took over 1,000 people with no known cardiovascular disease, performed a non-contrast CT, and demonstrated that the higher the Agatston score, which is a measure of coronary calcium, the higher the high-sense troponin I level. And that was the Abbott high-sense I assay. Here we're looking at people who were not known to have had an MI in the last few years, but had a cardiac MRI run. Now, cardiac MRI, if you look at late gadolinium enhancement, you can detect prior myocardial infarctions. So in this study, they looked at 248 randomly selected 70-year-old volunteers. They looked at the relationship between the Abbott high-sense troponin I assay and the presence of late gadolinium, and what they found was that there was more unrecognized MI, the proportion was higher, in those with higher high-sense troponin I levels. So to summarize really those two studies in CT and MRI, what you're seeing is that the high-sense troponin I levels were higher in people with unrecognized coronary disease or prior MI. The value, thus, of the Abbott Architect Stat high-sensitive troponin I assay really lies in the fact that there is a substantial body of research that has shown that this test provides greater accuracy in identifying a person's risk of developing cardiac diseases in the future compared to the current prediction tools, and that before symptoms are experienced. Multiple studies are available to support the use of the Architect Stat high-sensitive troponin I assay in this context, and we're going to run through some of the more relevant publications right now. So, summarizing the relevant publications, we would look first at, say, a study like Hunt that was published in 2018. The first author here was Fiola Sigurdardóttir. The senior author was Torbjörn Omland. And certainly the Hunt study has provided a huge amount of data in terms of looking at people with no symptoms or signs of cardiovascular disease and looking at future predictions of events. In this particular study, the conclusion was that in subjects from the general population without a known history of cardiovascular disease, high-sense troponin I provided prognostic information that was superior to that provided by high-sense CRP and may therefore be the preferred marker for targeted prevention. When we look at the table 2 here, we looked at associations between high-sense troponin I and high-sense CRP concentrations and cardiovascular death or admission for AMI or HF. We see that in those with values that are in the higher risk categories using the high-sense troponin I assay, and here we're talking, if you look at the bottom of the screen, at cutoffs of 4 or 10 for women and 6 or 12 for men, so that those with values below 4 or 6 would be categorized as low risk. Those with values above 10 or 12 would be categorized as higher risk, and those with values between 4 and 10 for women or 6 and 12 for men would be intermediate. What you're seeing is that using the low risk as a reference population, those with values of, say, 4 to 10 or 6 to 12 had a hazard ratio of 4.3 for the occurrence of those major events, AMI or HF admission. Indeed, at the higher levels of 10 or 12, you're seeing risk of a hazard ratio of, say, 9.76. So really those numbers were extremely high. Even when the models were adjusted for various risk factors, those hazard ratios remained very high. So you're talking between 1.8 or 3 and varying up as high as we say there for 4.3 or 9.7. So very dramatic compared in particular to what you're seeing underneath. And just below the high-sense I, you can see the categorization and hazard risk ratios given for high-sense CRP. And as you can see, they are higher, than the reference population, 2.2 to 2.8 in the unadjusted model, but they are not as high as those obtained for the high-sense I assay. And indeed, if you look at the net reclassification improvement, there was a much greater net reclassification improvement obtained when using the high-sense I assay versus the high-sense CRP assay. Indeed, for hard coronary disease, you were looking at 0.46 or 46% NRI for high-sense troponin I, and the corresponding figure for high-sense CRP was 26%. So using those categories, what we saw was that the male-female risk categories are those, as we say, that are included in the package insert. The data suggested that compared to the Framingham risk score, high-sense troponin I results in a significant reclassification of subjects to their correct risk category. Higher concentrations of high-sense troponin I in apparently healthy subjects are strongly correlated with increased risk of cardiovascular disease, and as stated in the publication, high-sense troponin I may therefore be better suited for cardiovascular disease screening in an asymptomatic general population than high-sense CRP. Next, we're going to look at WASCOPS, a paper that was published in 2016 derived from that study. And that study was, of course, the West of Scotland coronary prevention study looking at pravastatin in men with raised cholesterol. This looked at 3,300 men. Indeed, women were not included, as was the case for many of these studies that were set up a couple of years ago. And in this study, they were looking at 5-year follow-up. They were able to obtain 15-year follow-up using NHS databases, and the age range between 45 and 64 was the focus. This was published in JACC in 2016. What they saw was that compared to the lowest quarter, less than, say, 3 nanograms per litre, men in the highest quartile, values above 5 nanograms per litre, were at highest risk for non-fatal MI or death from coronary heart disease at 5 and 15 years, with a hazard ratio of 2.27. And then when you looked at the change in troponin concentration at 1 year, stratified by treatment allocation, and non-fatal MI or coronary disease death at 5 years, there was a really interesting set of findings. Compared, as we said, to the lowest quarter, people in the highest quarter were at highest risk for those endpoints. But indeed, there was a 5-fold greater reduction in coronary events when troponin concentrations decreased by more than a quarter rather than increased by more than a quarter, and that applied to both placebo and pravastatin cohorts. Pravastatin reduced troponin concentration and doubled the number of men whose troponin fell by more than a quarter, and that identified them as having the lowest risk for future coronary events. So this was really a landmark paper in showing the effect that troponin could have on how we approach treatment with statins. It demonstrated that high-sensitive troponin I can be used to predict future risk of coronary heart disease and to assess the response to statin therapy. It showed that troponin concentrations were reduced by statin therapy, and very interestingly, reductions in troponin concentrations are associated with better outcomes independent of LDL cholesterol lowering. These findings, according to that publication, suggest that high-sensitive troponin I has major potential to identify those at greatest risk and to assess their response, as in change at 1 year associated with future coronary risk, to interventions for the prevention of coronary artery disease. So you could both stratify the cardiovascular risk and guide therapy. When we look at how this could be applied in practice, the troponin could be used for screening and diagnosis, and high concentrations do suggest an increased risk of coronary disease in middle-aged hypercholesterolemic men. In terms of cardiac troponin for risk stratification, values above 5 nanograms per litre were considered particularly important. And in terms of guiding therapy and monitoring disease, they were reduced by statin, and indeed the better outcomes, that reduction, was independent of LDL cholesterol lowering. So that was certainly a very novel finding. Number 3, we will look at a study relating to the biomarker cohort that was published in 2016, troponin I and cardiovascular risk prediction in the general population. So the full title here is Biomarkers for Cardiovascular Risk Assessment in Europe. The N here is particularly important. You're looking at a population of almost 75,000 people, covering multiple cohorts across Europe. There was 14 years of cardiovascular mortality follow-up data available, and the mean age was about 52 years. What this study showed was that when they divided people by troponin I quintiles, with 2.5 being the cutoff for the lowest quintile and 5.9 nanograms per litre the highest, the hazard ratios reflected that the higher the high-sensitive troponin level, the more likely these people were to go on and experience one of these adverse outcomes, either cardiovascular mortality, cardiovascular disease, or total mortality. When we look at the net reclassification improvement, you can see from the top line that for all cardiovascular mortality, in other words, cardiovascular mortality across all age groups, the net reclassification improvement was 0.048. So you're talking about 4.8%, which doesn't sound to some people like a lot. But when we take into consideration that the total population of Europe would be around just over 700 million, we could be talking about reclassifying approximately 20 to 24 million people more accurately with the inclusion of high-sensitive troponin I when it's added to clinical and diagnostic findings above and beyond what is currently available. So that would be certainly a very impactful improvement. Of note, there was an association, of course, with selected endpoints from the Jupiter trial, which is one of the trials that we are going to go on and discuss momentarily. When we looked at the bottom of the table here, looking at the troponin I category, using cardiovascular disease as an endpoint, and the absolute risk reduction for those taking rosuvastatin, you can see that for people whose troponin I level was above 6 nanograms per litre, the absolute risk reduction was 0.74. So in individuals whose troponin I was above 6 nanograms per litre, which was a concentration near the upper quintile in that study, biomarker, and indeed in Jupiter, where the upper quintile was about 5.8, rosuvastatin therapy resulted in higher absolute risk reduction compared with people with values less than 6 nanograms per litre, whereas the relative risk reduction was similar. So, indeed, the addition of troponin I to variables with the established risk score improved the prediction of cardiovascular death and disease. So what we're really looking at here is a study that shows that for people whose values are in the top fifth of troponin I distribution, compared with the bottom fifth, there was really a very significant increase in mortality from cardiovascular causes and the risk for a first cardiovascular event. The addition of high-sense troponin I information to a prognostic model for cardiovascular death constructed of ESC score variables in this publication yielded an NRI of 0.048, which is of course equivalent to 4.8%. And this publication, which did involve, as we mentioned, almost 75,000 people, demonstrated that the Architect high-sense troponin I assay was reliable in detecting very low levels of troponin I and stratifying future cardiovascular risk by use of this cardiac-specific biomarker. So, a very important publication. Number 4, we're going to now talk about another publication, and this time it did include the Jupiter trial population. And of course, Jupiter, as we know, was justification for use of statins in prevention. It was an intervention trial evaluating rosuvastatin. So this trial looked at almost 13,000 people with 2-year follow-up. The age for women was over 60 and men was over 50. This particular sub-study looked at high-sense troponin I and BNP as predictors of vascular events in primary prevention. What you can see here is that they divided the population by tertiles. In men, the top tertile value was about 4.6, so rounding up to 5 nanograms per litre. And in women, the equivalent was about 4 nanograms per litre. This was published in 2015 in Circulation, and you can see that the cumulative incidence for first major adverse cardiovascular event was much higher in people whose values was above the tertile cutoff that we just mentioned. Indeed, the hazard ratios indicated that for the primary endpoint, the incidence rate was much higher for all of these endpoints taken together. So the occurrence of first MACE in this trial depended upon the high-sense troponin I category. And in individuals with high-sense troponin I values in the top tertile, there was an increased risk of cardiovascular mortality and non-fatal myocardial infarction. Secondly, rosuvastatin, which as we know is one of the most popular statins, was equally effective in reducing the relative risk of major vascular events across the categories of high-sense troponin I. But in the highest category of baseline high-sense troponin I, rosuvastatin was associated with the most substantial reduction in the absolute risk of cardiovascular events. Now we're moving on to the 5th publication, so you're really beginning to see a pattern here emerging, whereby high-sense troponin I is a very predictive variable. We all know that it's already cardiac-specific, and so this builds on the evidence that we've just presented in very large populations. We did mention a publication from 2018 on the Hunt study. Here is one from 2015 of particular interest to those of us who are interested in the prediction of cardiovascular events in women. As we all know, women have some disadvantages when it comes to the currently available risk stratification models and the diagnosis and treatment of cardiovascular disease. This study from Hunt, which is of course the appropriate nomenclature is the Nord-Trondelag Health Study, applied to a general population again with a population of almost 10,000, looking at 16 years follow-up at the time and an age of over 20 when the mean age is about 50. In this study, what was really interesting was the ROC curves, the ability of HSTNI to predict cardiovascular death. The AUC for men was 0.72. The AUC for women was actually 0.84. So when they looked at the ROC curves, of course, they were able to derive optimal cutoffs. And again, you see here, women, the cutoff was 4 nanograms per litre. So you're beginning to see a pattern of levels around about 4 appearing to be predictive in women. And levels here, say 6.7 nanograms per litre for men. We've already seen some evidence where 5 appear to be the appropriate cutoff. So you're seeing lots of 5s, 6s, and the occasional coming up towards 7. So you're seeing values averaging out at around 6 for men. So certainly those 5 publications were extremely important, but there are multiple other publications that we do not have time to review in detail on this webinar. However, we will quickly touch upon 5 that did provoke a lot of interest. But if you look into the available data, there are a lot more studies available. Of note, from the studies that we would present overall, we're giving you evidence on over 140,000 being the N altogether when they are added up. There are studies actually available across the globe on almost 200,000 people for the application of high-sense troponin I in this situation, where people have no signs or symptoms and you're looking to predict future cardiovascular disease. So there's a very large body of evidence. Here's an earlier study from cohorts that made up part of the biomarker study. So this looked at Murtagh and Sheck, which is the Scottish Heart Health Extended Cohort. This was over 15,000 people, 20 years follow-up. They were able to show that looking at cardiovascular events in men on the left and women on the right, the cutoffs here were again around about the 4 mark for women, 4.7, and 7 for men. So again, you're seeing these cutoffs beginning to average out across the publications. Those in the highest category, the 4th or top quartile category here, values above 12.7 overall, had 2.5 times the risk of a future cardiovascular event versus those that did not have detectable values with troponin I using the Abbott Architect assay. We look at thin risk, another study that was a component of the later biomarker publication, and this study was published in 2014. Their category 3 was above about 5 nanograms per litre overall, and you can see that for heart failure and overall major adverse cardiovascular events, there was a significantly increased likelihood of MI and heart failure. The hazard ratios there were about 1.12 and 1.11. Here's another study that incorporated men-only carefully, or CAPS, published earlier in 2015. In this one, they looked at troponin, BNP, and indeed IL-6, interleukin-6, and then looking at the sub-hazard ratios across thirds of the biomarker distributions, you can see that really the higher the troponin value, the more likely they were to have experienced an adverse cardiovascular event. That again was more evidence for its predictive value. PIVUS is a population of patients around age 70 in this particular study, published in 2013 by Eggers et al. And when you look at older populations, you can see that there are a lot of studies out there that show that our currently available models really are very difficult when it comes to older populations. While we do have some publications proving that HSTNI, as measured using the Abbott assay, is an independent predictor of all-cause and cardiovascular mortality, with adjusted hazard ratios of between 1.44 for all-cause and indeed 1.66 for cardiovascular mortality. So really you're seeing consistent relationships across these publications, even for older people. Here's another one for older people. And this, of course, from AGES, which is a population above the age of 65, men on the left, women on the right. And again, you're seeing hazard ratios in the 2.05 to 2.52 range, even when adjusted for incident cardiovascular disease above the top quartile. So yet another publication from the last few years reinforcing the capability. And if we decided to switch away from men-only studies and look particularly at older women, so as we mentioned, there are a lot of studies that cover men and women. There are some that looked at men only because of that tendency in the past for people to look at this disease as a man's disease, which we now know is not the case. But in typhus, looking at elderly women, there was again a consistent relationship between disease-free survival, disease-free being the disease here being coronary heart disease, and the quartile of high-sense troponin. So if they were above the top quartile, their disease-free survival was significantly less. The claim itself, as you will see, and to cap off, we really just want to look at what's in the claim itself, what's in the package insert that you will see. The claim as stated for the Architect Stat High Sensitive Troponin I. The statement is that values may also be used in conjunction with clinical and diagnostic findings to aid in stratifying the risk of cardiovascular disease, including cardiovascular death, myocardial infarction, coronary revascularization, heart failure, or ischemic stroke in asymptomatic individuals. In the package insert, you will see sex-specific cutoffs based upon the risk level. As we stated earlier, for men, the cutoff is 6, for low risk, below 6. For women, it's below 4. For high risk, it's above 12 for men, above 10 for women, and values between that would be moderate risk. When we look at the package insert again, there is evidence relating to prospective studies. It is important to note that the cutoffs were derived from published evidence. I think everyone listening to the webinar today, when they look at the publications that we've shown, will understand where those cutoffs came from. There was a consensus obtained at an advisory board by an expert panel, and so those cutoffs were derived from published evidence, and a consensus was obtained. As you can see, they were derived from studies that have been presented within this deck, like Wascop's, Biomarker, Hunt, Jupiter, and Morgan. So we adapted those into the package insert, and you will see those in what comes out for use. In conclusion, we know that mortality due to cardiovascular diseases is continuing to rise. In fact, we are facing a building epidemic. We know that risk stratification aims to predict the risk of a future cardiac event in people, in this circumstance, who appear to be healthy. It's very important to realize that we are talking about shifting assays that have been used for years in the emergency department for the diagnosis of myocardial infarction in people with symptoms, and for the most part moving them out of that setting into primary prevention. In other words, people who do not have symptoms at that time. Current tools like SCORE and Framingham do have limitations to their use. They can be inaccurate in their predictive capability. They can be inaccurate thus in terms of what category they put people in, low, moderate, or higher risk, and they are not incorporating cardiac-specific variables. So the key really is, of course, that being a cardiologist, I'm well used to treating people who already have symptoms, but ideally, we would rather they don't come to us at all. We would rather prevent cardiovascular disease and outcomes from happening in the first place. So the Abbott Architect high-sense troponin I is the first CE-marked cardiac-specific biomarker that aids in providing greater accuracy for estimation of risk, be that low, moderate, or high, for future cardiac events in apparently healthy or asymptomatic people when it's used in conjunction with clinical and diagnostic findings. It's very important to note that the existing risk factors are extremely important, but this provides incremental value in terms of its accuracy in putting people into a category, and it is the only thing that, of course, is cardiac specific. There is a very large body of evidence to support this. We've shown you evidence on well over 100,000 participants, and there are multiple publications that we have shown you, and also other publications that we have not had time to demonstrate as part of this webinar. You are welcome to go and obviously survey for yourself, but the body of evidence is one of the key things to remember going forward with this particular assay. For all its complexity in terms of its capability and its analytic capability, it is a simple blood test. So used in conjunction with clinical and diagnostic findings, it does aid in earlier intervention for high-risk patients and may avoid unnecessary tests and treatments in those who are truly low risk. The thing is that being a simple blood test, you do not need a separate blood draw. So you would do this as you would any blood test used for cardiovascular risk stratification, such as a lipid panel. It can be added on to the same blood draw. And it's important to note also that this is used to put people in the correct category, either low, intermediate, or high risk, and from there you will use your local cardiovascular disease guidelines to treat these people, but with more confidence than before. And so it really empowers patients and physicians in taking steps in terms of lifestyle and medications to help prevent future cardiovascular events. Thank you very much.
Thank you, Dr. Murtagh, for your informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen. Okay, now let's get started. Our first question, Dr. Murtagh, Who are the expected clinicians, prescribers for this test?
That's a very good question. The primary prescribers for this type of test would be expected to be primary care providers, such as general practitioners and internists. And other expected prescribers would include, of course, cardiologists, especially those that are involved in prevention. So really, we would be thinking it would be people who carry out cardiovascular risk assessment as part of routine care.
And who should I run this test on?
And another very good question. This test is intended for use in conjunction with clinical and diagnostic findings, as we mentioned, and it would be performed to complement your current cardiovascular risk stratification protocol. So really, as such, any patient that you would usually assess for cardiovascular risk per your local guidelines would be a candidate.
Now, Dr. Murtagh, our next question is two parts. What do you do with the HSTNI risk stratification results, such as elevated results? And is there any specific course of action to be followed? We'll answer this in two parts as well. So what you do with the results and the specific course of action. So compared to tools like Framingham, ESC score, or the ACC pool court equations, HSTNI has been proven, as you've seen with those publications, to more accurately categorize a patient into low, intermediate, or high-risk categories when used in conjunction with clinical and diagnostic findings. So really what we're saying is that healthcare providers should use their clinical judgment and follow their recommended cardiovascular prevention guidelines to determine the standard of care that's appropriate based upon their patient's level of risk. So, the risk category and the guidelines that are followed at your institution for cardiovascular disease prevention in clinical practice will determine that course of action that you should take. So it's determined by their risk status. So you treat that patient as we said, low, intermediate, or high risk according to your local guidelines. But what's really important to remember is we don't use any particular piece of information, such as the lipid panel, in isolation when we look at cardiovascular risk. And the same would apply to high-sense troponin I. It is very important to note that it is to be used in conjunction with clinical and diagnostic findings. We expect people to continue to use their clinical judgment. Now, our next question, should a single measurement be carried out or serial measurements?
Yeah, very interesting point. At the moment, the initial risk assessment is intended to be done with a single troponin test. So using one architect stat high-sense troponin I result. And that result will determine the risk category of the individual. So the risk category, be that, as we said, low, intermediate, or high, and the guidelines that are followed at the institution, whatever institution they are working at, for cardiovascular disease prevention and clinical practice, that would determine the frequency of troponin testing. So what we are saying is that for now, it would be done using a single troponin test, and you would follow your local guidelines as to the frequency of testing.
Now, what about biotin?
Biotin, yeah, something that is a huge concern to many of us. So it's extremely important to note that the Abbott assay, this Abbott high-sense troponin I assay, is robust to biotin interference, which is unlike many other assays on the market right now. And this is extremely important because, as we know, biotin supplementation is really becoming very commonplace. And people actually may not be aware that they are taking it, because biotin comprises an ingredient for a lot of multivitamin supplements. It is used for everything from multiple sclerosis to people undergoing chemo who are at risk for losing their hair. And indeed, it's used for hair, skin, and nail health in many women. So actually a lot of people are taking biotin and know that they're on it, but there are a lot of people who don't even know they are taking it. Many assays are vulnerable to biotin interference, but the Abbott assay that we're talking about here is very robust to biotin interference.
Thank you, Dr. Murtagh. We have time for one more question. How does HSTNI risk stratification compare with the current tools used by physicians?
The current tools, if you're talking about tools like, say, Broadening 2008 and the score from the European Society of Cardiology, those involve measures that are, those are very good, absolutely. As we said, the current, risk factors remain extremely important. People still need to take note of their blood pressure, their cholesterol. They need to not be smoking and be very aware of their diet and exercise. But those score tools, they do involve measures that are not specific to the heart. As we mentioned, they predict risk of atherosclerosis somewhere in the body, but they're not a signal coming directly from the heart. That may indicate, in fact, a hidden risk of future cardiac events like heart attack or heart failure. They're also, in many cases, as we said, heavily dependent on age. In other words, they're weighted towards the patient age, sometimes inappropriately, which does not necessarily provide the true cardiac risk status of a patient. So since troponin I is specific to the heart, we know that, as we showed with those publications, it can more accurately categorize a patient into a risk category that they should be in compared to the above-mentioned tools when used in conjunction with clinical and diagnostic findings. And we also know that those measures, as we said, so this is something that's really specific to the heart, and really this is providing incremental accuracy in terms of putting people into the right category. So it's a type of information, because it's cardiac specific, that we've never had before. And so, as we mentioned, really it's giving people a lot more confidence, because we know that it actually improves the accuracy of risk stratification compared with current tools when it's used in conjunction with clinical judgment.
Thank you, Dr. Murtagh. Do you have any final comments for our audience?
We are looking forward to working with healthcare institutions and physicians to introduce this indication, and I think we would welcome further questions on this matter, and we are delighted to have had the opportunity to present this data to the audience today, and thank you very much for your time.
Thank you again, Dr. Murtagh. Now, before we go, I'd like to thank the audience for joining us today and for their interesting questions. And I'd also like to thank LabRoots and our sponsor, Abbott Diagnostics, for underwriting today's educational webcast. This webcast can be viewed on demand through June of 2019. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. That's all for now. Thanks for joining us. Goodbye.